Good morning, my name is Jennifer Mitzman from the Ohio State University, and I'm talking about second victim syndrome. Second victim syndrome is what happens in terms of vicarious trauma to those of us who take care of patients. It can be as a result of medical error, but also as a result of an unanticipated bad outcome or any adverse patient event. I'd like to start with a day that started unlike many others, where a patient, I arrived, I took sign-on on my patients, and then I got a call that I was needed immediately in a room for a particular patient. I walked in expecting not to know exactly what to see, and there was a code in progress with a patient who had CPR going. I reminded the resident to pop the C-collar, started ordering medications, and asking some historical questions. When it dawned on me, this was already my patient. I had taken sign-on on him approximately 30 minutes before he attempted to hang himself in our emergency department. I still had to run the code and compartmentalize all of that information. We achieved a return of spontaneous circulation, but it was clear that he would not ultimately survive his injuries. We got him stable-ish and upstairs to the medical intensive care unit, where I proceeded to put all of that information in a box and go out and do what we always do, continue to take care of the patients who have backed up while we have been focused on this one. I finished my shift and went home for the day, visited with my family, and went to bed early, where I, of course, proceeded not to sleep a wink, hearing in my head over and over again the sign-out information, the code, and the parent notification, thinking perhaps that had I known something earlier, I might have been able to prevent this from happening. I was wide awake when I needed to return to work at 6 a.m. when my alarm went off. I don't know a lot of things with certainty, but I probably didn't belong at work that day. My head was not very in the game. But I did what we have all been acculturated to do and returned to my job anyway. I was already through the chaos and accident response and into intrusive reflections. These are the 6 stages of second victim syndrome, which I post so that as people think about how to provide aid, they recognize that there will be later stages of this syndrome where people need help. So what can that help look like? Well, local support consists of everyone in this room. All of us who work in this kind of environment should be trained to recognize when our colleagues are struggling. 39% of people will receive adequate support from a colleague, and an additional 29% from their immediate supervisor. That means that we have the power to help almost 2/3 of our colleagues recover simply by being kind, sympathetic listeners, and helping our colleagues to discuss difficult events. The next phase consists of trained peers. These are individuals who have undergone specific training to be trained listeners, and also including our safety and risk management in practicing just culture practices. What do I mean by trained peer supporters? Sometimes people use the term clinician lifeguards, which are people who are trained to sort of jump in and rescue us at a moment's notice. They should be present in all emergency medicine departments, intensive care units, and all of pediatrics, which are areas that have been identified as particularly high risk. They should be accessible in some form 24/7. Just culture practices include informing people of what to expect after a bad outcome, and it may also include assigning a peer supporter as part of your institutional root cause analyses or sentinel event committees. Practicing this allows people who are incredibly invested in finding systems-based solutions to participate. And lastly, recognize that some people will need expedited referral to a professional for assistance. When a crisis occurs is not the right time to try to find those people. You may have them in your community already. They often have expertise in working with first responders, such as police and fire, or prior military experience. And lastly, we need to debrief responsibly. There is a practice out there called the pause, which is literally a 10 to 15-second moment of silence after a stressful event. It allows people an opportunity to kind of mentally decompress before returning to work, and it shows 21% fewer people have intrusive thoughts at the 24-hour mark simply by being offered that 10 to 15 seconds. Hot debriefs are those done immediately after events. They can be helpful, but again, must be done responsibly. They should be brief and not mandatory. They're an opportunity to remind people what resources are available to them and to encourage them to seek help if they need. It is not the time to unpack heavy emotional baggage or attempt to assign blame. Why does it matter that we do this well? Psychologists tell us that people walk into these kinds of debriefs with one version of an event that didn't really go according to plan. but they may leave the room with 10, 12, 20 versions. And over time, those become their collective version. When they go to sleep and their memory crystallizes, that all becomes part of their recollection of the event. That can turn an acute stress reaction into full-blown post-traumatic stress disorder. So in conclusion, please debrief responsibly. Please build support into your institutional practices, and recognize that second victim syndrome can happen to any of us, but with colleagues as amazing as ours, we can still continue to thrive. Thank you.
Judges.
Great job. Actually, I think it's a really important topic for emergency medicine physicians. It's one of the more under-recognized things. And I imagine it was probably pretty hard for you to talk through that trauma again on a stage in front of people. So great job.